Okay, this is a very important chapter on anxiety and depression. We really have to look at normal aging, be able to recognize the subtle symptoms of anxiety and depression, come up with a real solid plan of care. Notice the difference between normal anxiety, appropriate sadness, and true depression. Going to provide you with some really interesting things about suicide in the elderly. This becomes a mental health review, just to have what we see in our elder adults, that mental health has been a very big stigma for this baby boomer age. Hedonia is where you no longer seek pleasure or enjoy life. Basic anxiety, the anxiolytic drugs that we can give, generalized anxiety disorders where it's beyond that just anxiety of life, undiagnosed OCD, panic disorders, post-traumatic stress disorder. We see this with our Vietnam vets. Many have gone undiagnosed and can manifest itself much later in life. What's interesting about post-traumatic stress disorder is this diagnosis wasn't even identified until is a true diagnosis until the late 80s by nursing. And they used to call it the Purple Heart Syndrome. We've known about it, but again, this age group of people we're talking about have seen traumatic things with war. Some drugs can cause substance abuse, anxiety disorder, corticosteroids, and some of your more common drugs. So we really, again, it becomes back to what are we monitoring with our people. If you remember back to mental health with anxiety and generalized anxiety disorders, we will give medications to try to help them in short term. And if you level it out from anxiety to depression to the psychotic disorders, we look at a lot of the different drug classes. So with depression, we have to realize, is this just they've lost a spouse and it's a minor depression, or is it a major depression where they're no longer caring for themselves and becomes that self-neglect? The best therapies identified for depression is the cognitive behavioral therapy and getting people to talk about what they're feeling. Again, this really will individualize where their role is in life. Multiple situations create a different response in different people. When we look at anxiety and depression, we are looking for the maladaptive response. Remember, in nursing, everything is from adaptive to maladaptive behaviors. Older adults may minimize the concerns about the depression, anxiety. They may not, because it's not interfering with the job so much, not interfering with caring for children. So it gets minimized about that. So as we look at anxiety, it really is our natural response to fear. A little bit of anxiety is good. It heightens your awareness. Um, you're more in tune to what's going on around you. But when you start to get to that moderate, um, it does start impacting us. And anxiety for that elderly is that inability to care for themselves, losing friends, loss of independence is huge. Just huge. And if you look at the medical conditions, COPD, that hypoxia, if you can't breathe, can you imagine what that does to your anxiety level? The financial concerns. Do I buy my pills or do I eat? And I've literally seen that in the Shopko in Wausau, picking up my own medications and having a woman in front of me saying, which of these do I need the most? And it was just appalling. That happens. Loss of sensory changes, that inability to see, the cognitive awareness. Again, those medications that can increase a little bit of the anxiety response. So what we need to do then is really do a good assessment. And I do have the tools out there for you to look at anxiety, depression scales. Because what we want to work with is identify, is it truly a um, DSM diagnosis of a true disease, or is it just situational anxiety and how can we help it? We always look for a differential diagnosis because, again, anxiety can exacerbate other medical symptoms because remember, it's your epinephrine that's putting everything into speed mode. So if you have underlying coronary artery disease, that can increase angina. I have truly seen this happen where I was doing some consulting with a local nursing home, and we were looking at why people were being sent to the hospital and what could have been done differently because the ambulance isn't paid for, your loss of dollars at the nursing home for that bed for the night. And the anxiety was being triggered by um, the family meetings, and the woman's family would show up. She just did not want to go, and her anxiety exacerbated so bad, she ended up with chest pain, and they'd end up sending her to the hospital. Instead of just really looking at the situation and she was alert oriented and she didn't want to go, then don't make her go. Why take her away from that stimulus? Anxiety and dementia is extremely difficult, and people with dementia also have anxiety, and it it shows itself in a lot of agitation. It's that loss of control, especially earlier on in the dementias where um, they're losing that sense of reality, forgetting things, people's faces are changing so that even loved ones can trigger anxiety if they're trying to hug them, but they don't recognize that. And then we're medicating them inappropriately instead of really trying to look at how do we approach the environment differently to decrease that anxiety. Counseling is appropriate. We need to keep to a routine. Again, if you look at the type of therapies available, that cognitive behavioral therapy is really the best. Short-term anxiolytic drugs, a little bit of Ativan, maybe some Xanax. If we know we have to put that person into a situation that's going to increase their anxiety, stress reduction is available, soothing music. There's a lot to be said about that with music with stress reduction, is knowing that if you ever went and got a massage, the background music is set at 60 beats a minute. In that way, what they're trying to do is get your heart rate and your breathing to slow down so that you come to that state of relaxation. Not getting enough sleep can make you even edgier. Staying active as possible. And again, avoiding those triggers, as I talked about with that woman, that her trigger was going to the family conference. She just did not want to go. Depression becomes is is just amazing that if you look at almost 20% of women over 65 are diagnosed with depression. Men over 86 are the highest risk. And again, it is due to that. They were the caretakers, they were the money makers, they were in control of the family, and now they're dependent on other people. That's really a big trigger, that loss of independence, loss of self. When we see a major depression, it's just that, again, a hedonia where there's just absolutely no pleasure in life at all. Their grandchildren don't make them happy. There's just nothing that can snap out of that. We can have minor depression, more situational, the dysthymia, the late onset depression, where it really, they've been able to stuff it in it. It triggers after some event. We know that men and women behave differently, and that's just the old men and women adage. But if you look at this group of elderly people that we're talking about, or the older person, men have always been more stoic. Somatic symptoms can be very misleading. We've got to be really tuned into the physical symptoms, just losing that interest in eating, physical pains that hurt worse. People present differently from a total catatonic state to a psychotic state. So it's just knowing your person that you're dealing with. Now, here we're talking about people with diagnosed true major depression. We do know that disease, cancers, stroke really increase the risk of depression, chronic disease. Excuse me. I do have the geriatric depression scale out there for you to see. We're looking at time frames of over 2 weeks. Again, knowing what the differential diagnosis is. Is it a true physical problem where they're anemic and so they're not engaged, they're fatigued, they're resting more? Or is it an Alzheimer's dementia where that anxiety, depression is withdrawal in relation to the symptoms that we're seeing? So again, with anxiety and depression, we always look for a differential diagnosis. Is there another trigger? Symptoms consistent with depression really have been shown to precede dementia in both men and women. It's kind of that internal, my body's changing, but yet really can't communicate it. Traumatic brain injury is another big one. Strokes, TIAs. And the medications that are best are SSRIs and SNRIs, some of the atypical antidepressants. Depending on the cognitive level, counseling and therapy may just not be an option, especially with people with more advanced dementias. This is the biggest thing, is we need to really be aware of suicide. Are they starting to give things away? Spending more money than normal, withdrawing more, speaking about it, doing some data research and knowing a lot about of the clientele I've worked with. I just want to share with you that historically the elder population, those 65 and older, have had consistently the highest suicide risk. They can do it. Men like to use guns or hang themselves. It's usually triggered by, again, an incurable disease, cancer, chronic illness, loss of a spouse. That's social isolation. The other thing is they're more likely to be successful. And that's the scary thing as well. And the statistics that are available on suicide show that the baby boomer group, the reason why gerontology and becoming more in tune to this population are the highest risk of suicide documented. So as the nurses caring for this changing population, you really have to be more in tune to your clients and where they live, what they have available, and if they have a plan. So again, as we look at that, depression and anxiety are very common, especially those with limited social support or financial resources. It will be our role to look at all aspects of that mind, spirit, body, make appropriate referrals as we can, and early recognition will improve the quality of life and prevent those unnecessary outcomes.